That's it. So let's start with our things. This is our team medical MCQ for all, not going in much detail, but for those new, very quickly, what the medical MCQ for all is the company, right? Not just the website. So we providing lots of things, right, which definitely going to help you for your study. There are few fans of ProMetric 1000 MCQ books, so you can get it. We have online subscriptions as well as coaching. What we are doing every Sunday, but it is done by our coach every day, Monday to Saturday, right? At least 1 to 1.5 hour a day. So you can join. I recently published some promotional things as well by lots of doctors' request. So almost your cost is half, almost half. So nothing better than this, I think. I mean, this is the golden opportunity. So those who wants, just contact me or in the group. We'll make a batch of 10 and then we'll start. So that significantly reduce the financial burden to every student. That is our main goal, to educate. That is why we are coming up with this. We also provide Oman Viva coaching and study material, Dataflow. We have one short package, and humble request. Mobile application is, believe me, it's a tremendous, very user friendly. Probably many doctors are using. Any doctors, those who are using our mobile applications, any feedback, quick feedback? Mobile application, Android and iPhone. Anyone? Anyone using our mobile application? No one using our mobile application here in this group? Yeah, you can directly tell a doctor.
I can use.
Yeah,
Yes,
yeah.
I
So how's your experience? How's your experience?
it's very
It
easy
was
to
good.
use. Wait,
It is
whatever
good.
the place, very easy to use.
Right. So it's a user friendly, right? I think
Yeah, it's
I'm,
very user friendly.
yeah, yeah.
While doing the my duties, I am using the actually the app. It's very
Great,
easy to use.
wonderful. So same things you can completely replicate on your mobile, right? Very smoothly. Wonderful. So that's the again advantage. So I will share the link of Android and Apple both after the lecture, right? On in our group. So those who are not downloaded, you can download the mobile application. So that would be very, makes your life bit easy. So we are trying here to make the lives easy, right? So this is myself, Dr. Munjal, and I'm by profession hematologist, oncologist, and by passion, I am a coach. Obviously, you can see the passion in me, and almost practicing for more than 15, close to 20 years in hemato-oncology and bone marrow transplant unit in corporate hospital here in India, and almost more than 10 years of teaching experience, online, offline, and treated more than 100,000 patients so far, which is registered in corporate hospital in last 20 years. So I'll try to club up my clinical knowledge with the academic knowledge. Dr. Arti, as I told you, she is a consultant pediatrician, and she is a gold medalist. She is in our team taking regular everyday lectures for pediatric. Maddie is an emergency physician based at Oman, and she is again a brilliant coach. Many doctors probably fan of her. She is Dr. Shikha. She is a consultant gynecologist and also taking regular lectures. So I, Varun, request her to take a one lectures as you requested, and Dr. Ankit is a super specialist. He's a consultant gastroenterologist. He is also from my same city and my colleague as well, good friend of mine as well. Dr. Meghna is taking care of data flows and other things, and there are a lot of other teams like support Pallavi, many people knows, and then IT teams and all. So it's keep increasing. This is our contact detail. This is latest book updated we in January, almost a month back. So this is one of the best book, and all high yield 1000 MCQ we compiled, and those who interested they can order that sale. So let's start to our main things, right? So this is quick review. uh, First question, you need to do a time management, right? Because time management is extremely important. So you won't have more than 1.5 minute to 1 minute to 1.5 minute for every MCQ in your exam. So you can't be a, I mean, take 5 minutes, 10 minutes for one question. If you don't know, you go ahead, make it review later on. Once you out of 150 question in DHA, solve the 100, what tricky 50 you do it last. Because if you waste a lot of time, then unfortunately end of the day, you miss the questions which you absolutely know the correct answer. So I don't want to miss you any questions. There is no negative marking, 3 attempts, right? 65 upper the higher the better. The 65 is the good number rather than keep a mindset of 60. So make a 65 in your mock test. When you get 75, that is the right time to go and give the exam. So let's start. First questions in front of you. A 68-year-old woman visit her physician with a solid peanut-shaped hard mass in upper outer quadrant of the left breast. The biopsy of the lesion reveals infiltrating ductal carcinoma. What is the next step in management? You going to do a lumpectomy with lymph node sampling plus radiotherapy, modified radical mastectomy, that is called MRM, modified radical mastectomy plus radiotherapy, right? Neoadjuvant chemotherapy plus lumpectomy plus radiotherapy, and tamoxifen and radiotherapy. Your time starts now. You have a very limited time. Treat like exam. Think over it for 60 seconds, 30, 40 seconds. We will discuss each and every MCQ. We will not make it fast. Whatever we discuss at length. So this topic is done for you. Believe me. Breast cancer today is almost done for you. You can post your answer in the chat box so I can discuss with you guys. Yes, Dr. Azil, good morning. I'll start with you. Is that okay?
Sir, good morning, sir. Yes, sir.
Yes. Yes.
Uh,
Now just let's discuss. So it's learning for everyone. So I'm first of all congratulate you because you are interacting very nicely in every lectures. So I must
thank
thank
you,
you.
sir.
Yes.
Thank you.
Now, what makes you to think of neoadjuvant chemotherapy? Other people think your answer. Don't go. I mean, she is telling D, so you have to tell D. Make your own answer with the explanation. And now we'll start explanation. And if it is wrong, make in your note that this is a wrong question. If this comes, it's wrong in your. So check your score end of the day. Out of how much? Out of 15, 7 correct, 7 wrong means it's a 50% score. Not good score. Try to improve. Yes. Yes, Azil.
Sir, the biopsy shows infiltrating ductal carcinoma.
Wonderful.
So,
So let's have a little basics. Three things, new doctors. Without knowing the three things, it's impossible to crack any questions. This is called triad. One, this is diagnosis. Another is investigation, and third is a treatment. So we have to do three MCQ in one MCQ. So at least we can make this MCQ a three MCQ. So first diagnosis. So what's a diagnosis first of all? Go in that way. Make a practice every day. Makes your life easy. Yes. So what's the diagnosis of this patient? Azil.
infiltrating ductal carcinoma.
Infiltrating ductal carcinoma of breast. So this is basically a CA breast, right?
Yes,
Fine.
sir.
Wonderful. Now what they are asking, what is the next step in management? Management is something related to the treatment. So don't confuse yourself. They probably not give you the clue that, oh, what is the treatment? Management. Management includes sometimes investigations as well in few questions, right? So it's little disturbing. So I'll mute all. Right. So this is one request. If you somebody is not interacting, make your mic mute, please. Right. It really distract me completely. So this is the diagnosis is breast CA, investigation and treatment. So they are asking something as well about management. So what makes you to think of neoadjuvant chemotherapy? Yes, Azil. Speak
Sir,
right, wrong, whatever is in your mind. Speak up. That's it.
okay. Sir, neoadjuvant chemotherapy is preferred in lesions that are more than 2 centimeters. And this being a cancer, I mean, carcinomatous lesion, I think neoadjuvant chemotherapy is appropriate.
So do you
She's
know
right.
neoadjuvant chemotherapy? I mean, neoadjuvant chemotherapy you need, right? So, what are the criteria of neoadjuvant chemotherapy? Do you know the criteria of giving the chemotherapy? Neoadjuvant chemotherapy? One,
No.
two, three, four, five. No, it's fine, no problem. So, I'm just trying to understand from you. So, let's a little discuss with another doctor. Dr. Preeti, what makes you to think of modified radical mastectomy plus radiotherapy?
Because they already it has been with the biopsy it has been diagnosed as cancer.
Okay, wonderful.
So better to go for the radical mastectomy, or any mastectomy need to be done because we don't want to keep any spreading from the cancer. And usually for the breast cancers, we start with the chemo or with the radio, depends on the size of the lesions. I'm not sure with the size of the lesions, but I think it is a modified radicalectomy with plus radio. Otherwise, plus chemo. That should
Okay. So your answer is a C.
Yes, sir.
Right. So one more thing, Dr. Dipti. Why you selected, why you selected C? Why not A? If I can tell you, A is a better option. Why you want to remove all the
Because
breast?
they already the sample has been sent through biopsy. That is what showed revealed already infiltrating ductal carcinoma. Why again to get diagnosed with lumpectomy? Because to get a lump better in carcinoma, that too infiltrating carcinoma, to remove the cancerous breast is very important.
Mhm. Let's discuss, no problem. So what is the problem in doing the lumpectomy? Why you want to remove the natural organ of the body, that is breast of the woman, right? Which can be preserved. Why you want to remove?
I would suggest a lumpectomy because breast conservative management is more important since it's just a peanut-sized tumor.
So
So
peanut
I
size
would
tumor
actually
is
go
a
for a
small tumor, na?
lumpectomy.
Yeah, so
Yes.
peanut size is small tumor, na? Obviously small tumor. That is peanut
Yes, so
size is
there's no
less than 2
point in going
centimeters.
for a radical mastectomy.
Okay. Any comment, Dr. Preeti?
Recurrence of the cancer can be there after the some or other stages. So.
Sorry, I'm not getting clear.
Recurrence of the carcinoma can be there in some or other stages if still the breast remains. I think so.
Right, but you are giving the radiotherapy, no? Both the patient, if you can see, you are giving the radiotherapy to prevent the local recurrence. So here you are giving radiotherapy. Here also you are giving the radiotherapy. So you are taking care of the local part. So why you want to remove the whole breast?
I feel just for the recurrence, because we are going to give radiotherapy not for the whole breast, through the where the cancer is there only we are going to give the radiotherapy, not whole breast also.
So just for your knowledge, it usually given on the whole breast, right? And the tumor bed, and it just not given to the breast, it also give to the axilla, for your knowledge.
Excellent.
And it also gives to the supraclavicular region and internal mammary areas. So
Okay.
that whole part will be covered in a breast radiotherapy, not just the tumor of 2 centimeter area. It's radiate to the tumor bed surrounding and adjacent lymph nodes. So 3 areas I told you already, clear cut.
Yes, sir.
Supraclavicular, axillary, internal mammary, right? So this is how it has been given, right? So now let's discuss more questions, then I will come to the complete treatment plan of breast. So whatever they ask, right? Yes, Dr. Preeti, I'll ask each and everyone, what is the commonest histology? There are 10 questions in this questions, 12 questions, at least I make 12 questions. This is question in exam, DHA, hard, MOH. Commonest histology in breast cancer? Anyone? Quickly? Open for all. So write down commonest histology is invasive ductal carcinoma. Or another name is infiltrating ductal carcinoma. Both are same thing. Don't get confused in exam. Invasive ductal carcinoma or infiltrating ductal carcinoma, right? That is the term. Second thing, breast cancer histology. So if some patient comes to you and tell that there is a bilateral breast cancer, so what do you think? What is the most important common histology in bilateral breast cancer? Which histology is most common in bilateral breast cancer? Invasive lobular carcinoma. This is invasive ductal carcinoma. This is invasive lobular carcinoma, right? So let me tell you, right? This is the duct and this is the lobule at the end of the breast. If you go and see, so this is the duct, this is the duct, right? So this is duct and this is a lobule, this is lobule, right? So invasive ductal carcinoma is most common, usually unilateral. Invasive lobular carcinoma is usually bilateral, or invasive lobular carcinoma, if you come, so say for example breast cancer, you have a lump in the breast, it turned to be invasive lobular carcinoma. Better check the opposite breast as well, because they sometimes present with the bilateral breast cancer at the same time, right? Bilateral breast cancer at the same time. So this is second question in exam. Third question, best prognostic thing in the breast cancer. Which things decide the prognosis? If I can tell you, the histopathology is a best prognostic factor, grade of the disease is best prognostic factor, stage of the disease is best prognostic factor, or family history of the breast cancer is the best or worst prognostic factor. Best or worst, I mean, you can on which decide that this disease is good, this disease is bad. Only one thing, which is the most important, right, which decides the prognosis of the breast cancer, and that is the stage of the breast cancer. So which stage of the breast cancer, right, it decide the things, right? I will give this slide, share with you, don't worry. So if you are writing well and good, not, I will share this by end of the evening, right? So three questions we understood. Which quadrant most commonly seen in a breast cancer? Which quadrant? So there are four quadrants in the breast, just for your knowledge, you must be
Upper
knowing.
lateral.
This is the breast, this is the, right, this is arm. So if you divide, there are four these things, right? This is upper outer, this is upper inner, this is lower outer, this is lower inner. So which breast area, right, as the commonest, which quadrant most common in breast cancer? So if you see
Upper outer,
100, excellent. So upper outer, so upper outer is the most common. So whenever any patients comes to your OPD, in your emergency or in your hospital with upper outer breast lump, upper outer breast lump, this is physical examination, right? So you need to say, and this is upper outer. If you don't know, make it clock, 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. So anything between 9 to 12 o'clock is upper outer in general, for your understanding. So this is how I decide in my OPD. Okay, breast lump for 1 month, 2 month, 3 month, I'll check. Upper outer quadrant, I have more suspicious, it could be, right? Then I'll check the examination, local examination, axillary lymph node, supraclavicular, blah, blah, right? And then I'll go for the true cut biopsy, right? Or core needle biopsy. So that could be the diagnostic things, right? So once you have a suspicious on clinical examination, do mammosonogram and go for the biopsy. This is again exam questions. How many percentage of chances of the hereditary breast cancer, right? How many percentage chances of hereditary breast cancer? So mother has a breast cancer, how much percentage to daughter, right? Grandmother and mother has a breast cancer, how much percentage to daughter, right? So that's a very important. When to do BRCA1 and BRCA2, I will tell you in the next slide. Criteria for surgery, chemo, radio, hormonal targeted, I'll tell you in the slide. Mammogram age for the general population and high risk patient. Anyone? Mammogram, general guideline, all exam questions, believe me, but it is the one liner. They won't ask you one
40
liner,
years, sir.
right? So it's a wrong answer. Usually 50 years,
50.
especially in India and most of the country, it is in a normal population. So if your mother asks, beta, I need to do mammogram or not. So if it is a 50 years or older, your mother, your sister, your aunt, or your family and friends, more than 50 years, general population, no family history of breast CA or ovarian CA in family, in first degree relative, 50 years. Means normal, healthy individual mother or sister. 50 years plus, you need to do mammogram every 1 to 2 years. That's it. This is a WHO and international guideline. Those who have a family history, say for example, mother has a breast cancer at age of 45 years, right? Then they need to do it early, 10 years early, right? So if mother got the breast cancer at age of the 45, then you should ask at 35 years, right? If she get at 50, then age will change to 40. For daughter, this is mother who has a breast cancer. So ideally 10 years earlier, they should start screening, right? To pick up, if at all, any chances of hereditary breast cancer. And it is very common in a first degree relative, mother, real sister. If there is a first degree relative cancer, you must go and check, right? This is what the thing is. How small can lump can be detected a mammogram? How small? 1 centimeter, 2 centimeter, 3 centimeter, 4 centimeter, 0.5 centimeter. How small, right? You can detect on mammogram. Important question. Most common cancer in female, and what medication increases and decreases the risk of breast cancer? Very few high yield questions I compiled here for your understanding, right? So it's a very important discussions going on for breast cancer. So this is all the answers. I will share one slide as well. Commonest, I told you, invasive ductal carcinoma, as I told you, right? Answer of first questions. Bilateral, it is invasive lobular carcinoma. Stage of the cancer decide the prognosis. Upper outer quadrant is the most common quadrant for the breast cancer amongst all four quadrants, including axillary tail. How many percentage chances of hereditary? So 5 to 10% of the breast and 10 to 15 of the ovarians, they are hereditary. 5 to 10% is not small number. So if 10 women are there having a breast cancer in young age, out of 10, one patient has a hereditary breast cancer. So 5 to 10%, and that is 10 to 15, right? I will explain 6 and 7 together, right? Here one important things, which medication increases and decreases the breast cancer. So estrogen, if you have more estrogen and if you have more progesterone, it increases the chances of breast cancer. And if you block the estrogen by giving anti-estrogen drug like tamoxifen and anastrozole, it reduces the risk of breast cancer. And if you block the progesterone, it also reduces the breast cancer. So it is very commonly questions confusing every time to everybody. So estrogen is not good for the breast. I mean, for the breast cancer, basically. So that is why, what is the risk factor of breast cancer? So early menarche, if you have word early menarche in female and late menopause, these two words are extremely important. Early menarche means menses start early and stops late. So means you are more time exposed to the estrogen. Because of this estrogen, more exposure, that is why it is early menarche, and late menopause is a risk factor for breast cancer by WHO. So you go and check it, the risk factor of breast cancer, what makes the female to prone more to get and develop the breast cancer, is one of them is early menarche and late menopause. Another is BRCA1 and BRCA2. This is a genetic risk factor, right? BRCA1 and BRCA2 is a risk factor for breast cancer. The biggest example and very famous celebrity, Angelina Jolie. So go and read little article out of the box, not just the DHA had much, but it's an interesting story. So Angelina Jolie has a BRCA1 and 2. She did bilateral prophylactic mastectomy followed by implantation, silicone implant of the breast. And after that, this test and these things become very much popular globally. What is BRCA1, BRCA2? So that gives more little popularity after these things. Now, the most excellent things which you 110% not get in any book in the world, believe me. So these are the 5 modalities of the treatment. Some few people knows as well: surgery, chemotherapy, radiotherapy, hormonal therapy, targeted therapy. These 5 treatments across the globe available for breast cancer treatment. So any patients you are treating across the globe, these 5 things will come in mind, and these 5 things you should keep in mind. In surgery, there is a 2 surgeries: modified radical mastectomy and another is breast conservative surgery. Modified radical mastectomy example, this is the breast and this is chest wall. You completely remove the breast. This is say for right breast, this is left breast. So left breast nothing, it's a flat chest, completely 100% breast is removed. MRM, modified. And breast conservative is what? Right side is there, left side is also there. Breast, what you did it, you just remove the lump. This is called lumpectomy, right? So completely the normal natural breast is preserved. That is why it is called breast conservative surgery. You conserve the affected breast by removing just lump and you did the axillary clearance. That's it. This is the common basic principle surgery, right? What are the indication of doing surgery? So tumor size is less than 5 centimeter. You offer, usually node is negative or zero node. Have you heard of the TNM classification? Anyone? Tumor node metastasis. This is the international classification, and T stands for the size. So T1, T2, T3, T4. This is the size. Larger the size, more the number. Node N0, like here T0 means carcinoma in situ. N0, no node involved, 3 node involved, 9 node involved, more than 9. So N1, N2, N3, like that. So it is called as a TNM classification, and M stands for metastasis. M0, no metastasis, M1, distant metastasis. This is the basic general principle of any breast cancer, head to toe, any cancer. It is classified in this way only. T0 to T1. Size may decrease, like T1 of breast cancer is different from T1 of esophagus cancer. T1 of breast cancer is different from T1 of ovarian cancer. That, but the principle would be same. This is how they classify T1, T2, T3, T4. So N0 means node is 0, right? In that case, you prefer the breast conservative surgery, right? So indication of breast conservative surgery is small. Peanut is less than 2-3 centimeter. So they deserve the breast conservative surgery. You don't need to remove the whole breast for the lady, right? You can conserve the natural organ of the body, right? For psychological purpose, for social life, for the cosmetic life, for a lot of things. So you directly don't, and you always offer the patient breast conservative surgery to all patients as far as possible. This is what we do in our hospital every day, right? So here, these are the two things, right? So when the tumor size is small, node is negative, it is not spreaded anywhere, means M0, no metastasis, you go and give the options of breast conservative surgery. That's all. So this is the surgery. So later on we review the questions. Chemotherapy, where we give the chemotherapy. So chemotherapy, there are three types of chemotherapy. I mean, word neoadjuvant chemotherapy, adjuvant chemotherapy, palliative chemotherapy. These are the common three words which we use in our day-to-day practice in clinical medical oncology. Neoadjuvant, when there is a chemotherapy is given before surgery. So you give the chemotherapy and then do surgery. So before surgery, if you give chemotherapy, it's called neoadjuvant. When you do the surgery and then give chemotherapy, it is called as a adjuvant. So this is reverse. First chemo, then surgery, it's neoadjuvant. First surgery and then chemo is adjuvant. Simple, right? So it's a little change in the sequence. And palliative is just to support the symptom, to alleviate the symptoms. If patient has a prostate cancer with extremely bad pain in the bones, right? So you give some chemotherapy, palliative, which reduces the pain. It will not going to cure. Palliative means no cure. Palliative means just the symptomatic treatment to improve the quality of the life of the patient, to reduce or obsolete the symptoms of the patient. That is called palliative chemotherapy, right? So here goal is not cure. Here the control the symptoms. Here adjuvant goal is cure. So this is the curative intent. This is the palliative intent. So we use term in our clinical practice that, oh, what chemotherapy? I'll tell my resident, oh, this palliative chemotherapy means the goal is not the cure. It's to alleviate the symptoms. So these are the three words. The neoadjuvant chemotherapy specific, the reverse, tumor size is more than 5 centimeter. Nodes are positive. In this case, you give the neoadjuvant chemotherapy. Dr. Azil, right? More than 5 centimeters of tumor, node positive, better you go first chemotherapy. Why you want to give first chemotherapy, not surgery? You are trying to reduce the tumor from big tumor to small tumor, and then you operate the things. That improves the overall survival. It is studied in thousands of clinical trials. And that is why now in advanced or locally advanced breast cancer, first we give the chemotherapy 4 to 8 cycles to the patient, debulk the disease, reduce the disease, right? And then operate. This patient lives longer. Then you give the surgery and then chemotherapy. This is very well studied. So it's in the guideline now. So every patient don't need the operation. So we have a mindset, oh, breast ye operated, that's it. Don't give operate. Try to understand what the stage of the disease, right? So if it is advanced or locally advanced or these things, right? So look at the two things, tumor size and nodal status. That's it, right? So if it is a small size like this peanut shape, so first you do the surgery, you did the breast conservative surgery, and you give the chemotherapy if required, right? If required, right? So this is the second thing. Third thing, radiotherapy. Which patient needs radiotherapy? So three things. One thing is that tumor is more than 5 centimeter, larger tumor, high risk of local recurrence, nodal status is positive, they need radiotherapy. Third important thing is a breast conservative surgery. So those patients who underwent for breast conservative surgery, 100% radiotherapy is mandatory. 100%. You are trying to remove just lump, means if there is a small particles is also there in the breast, there is a risk of local recurrence, and that is why radiotherapy is 100% mandatory across the globe. Got it? So this is third thing, right? So we deserve, our patient deserve. Why? Because we underwent for breast conservative surgery, and now breast conservative means surgery. So what could be the answer? Breast conservative surgery followed by radiotherapy, right? Biopsy has been done. Tumor is small. So what we'll do? We'll operate. What you operate, MRM or BCS? So we'll do BCS. And when you do the BCS, irrespectively, whatever the tumor size, whatever the nodes comes in the report, histopath, you need to give radiotherapy. Hormonal therapy means something related with hormones. So there are two receptors, estrogen receptor and progesterone receptor. If it is positive, you should give the chemotherapy, hormonal. If it is positive, you give. Another confusion, both should require positive. Answer is no. If ER is positive, only ER positive, give hormonal. Only PR positive, give hormonal. Both positive, give hormonal. Both negative, don't give hormonal. Is that clear? Yes or no? At least interact. Yes or no?
Yes.
Wonderful.
Yes.
Wonderful. Wonderful. So this is
Yes, sir.
hormonal treatment. And last but not the least, targeted therapy means you are targeting some these things. So what you target is here the HER2, right? Human epithelial growth factor, HER2. If you heard the name, human epithelial receptor type 2. So HER2, if you HER2, two possibility, HER2 positive, HER2 negative. If HER2 positive, give one drug that is named as a trastuzumab. If negative, don't give. That's it. That's it. This is complete 100% treatment plan of any breast cancer. So you don't need to mug up. You just need to see what is tumor size, what is nodal status, what is ERPR status, what is HER2 status. Once you know all these details, then you can plan out the treatment. This is how I do for last 20 years in my practice for breast cancer. We are treating hundreds of breast cancer every month. It's one of the commonest cancer in India and Asian countries and Middle East country and European countries as well. You go and review the literature. In female, breast cancer is the most common. Second most common is a cervix, right? So you must know, irrespective of the exam, whether they ask or not. If something goes wrong in our family, we should know na, what to do, what not to do. So this is the basic things. I try to make it simplified for you and try to give you the idea. Azil, did you get the point?
Yes, sir.
Any confusion?
No, sir. I'm clear now, sir.
Let's go back to the questions. What now they are saying? Now probably you can see the better picture than now. 68 years female. Obviously it's a postmenopausal. So postmenopausal, right? So 68 years female, solid. Malignant tumors are usually solid, not cystic. Peanut shape less than 2 centimeter. Hard mass again favors malignancy. Cystic mass are soft mass. This is hard mass. Upper outer quadrant, again the risk factor. So a lot of age is a risk factor. Solid mass is a risk factor. Upper outer quadrant. And on top of that, the best thing is the biopsy. Biopsy also positive for invasive ductal carcinoma or infiltrating ductal carcinoma. Now you did the diagnosis. Now you want to do the treatment. So treatment, two options. So we opted for breast conservative surgery and we opted for breast conservative. RT is mandatory. So now what do you think? Is it a good answer? Azil?
Yes, sir.
Lumpectomy is basically the breast conservative surgery where we remove the lump and lymph node. Obviously, when there is a breast conservative means lump and lymph node. That's it. And followed by radiotherapy. That's it. So no need to completely do the radical and remove the whole breast for the patient, especially the less than 5 centimeter, right? Try to preserve the breast. This is 68. Probably she may not have concern. But what if I tell you this lady is a 28-year female? Same case, 28-year female. Then it is 110% breast conservative surgery is required. How looks bad to a 20 years female where you remove the whole breast? How bad? One breast is normal, one breast. It affects the marital life later on. When she cured of breast cancer after 5 years, when she become after 5 years, she become 33 years. She is quite young and she feels, sir, my breast is. I have hundreds of patients who comes and tell me in the OPD, sir, now I have 5 years, 6 years, 7 years, right? I am cured. But what to do with the flat chest? Then we try to implant the breast with silicone prosthesis. So doing all this drama, better do the breast conservative surgery as far as possible. I'm not trying to insist you to do each and every patient breast conservative surgery, but try to triage, try to evaluate such patients for breast conservative surgery before jumping to MRM. That's it. This is what my take home message, right? If tumor is large, if patient wish not to remove, if this patient 68 tells, where surgeon always give two options, MRM, breast conservative. If patients opt MRM, you have no choice. Believe me, you have no choice. You go for MRM. That's fine. But it's your duty to tell them that this is one of the best option you can opt for. Let them think. And if you explain properly, I've seen hundreds of patients, they'll go for breast conservative surgery, right, for these things. Is that clear to everyone? Yes or no? Now, any questions open for house?
Yes, sir.
Another questions was there, right? Established risk factor of breast cancer. You should know. I know I'm going little detail, but this is, I don't want any female to die of breast cancer, especially by medical negligence. Not picking on time, I would be extremely unhappy. So age more than 50 is a risk factor. BRCA1, BRCA2 risk factor. Radiation exposure is a risk factor. Childbirth after 30 is a risk factor. History of breast cancer and ovarian cancer in first relative. Obesity is again a risk factor by WHO. So those who are obese, try to reduce the obesity, and hormonal therapy like estrogen and progesterone exposure increases the risk of breast cancer. So these are the well established risk factor for the breast cancer. So whosoever has this modifiable things, you can change. What is modifiable means you can change. Something you cannot change. What? Age you cannot change. You cannot stop your age. It's keep going. Right? Having BRCA1, BRCA2 is not in your hand. Your mother has, you have. You cannot. But obesity, regular exercise, right? Not having a sedentary lifestyle. These all are very important. Very important. Right? BRCA1 and BRCA2, when to do? That was one of the questions. So family history, early onset of breast cancer, and if you have a family history of ovarian cancer, you go and check. So when you have to check the BRCA1 and 2, when you have a family history of breast cancer, you should go breast or ovary. Another thing is a family history of male breast cancer. Even you should go for BRCA. Two, three things not mentioned here, but we do clinically practice. Triple negative breast cancer, we do the BRCA. Triple negative, young age, and family history. These are the main three things in our OPD we do. Right? Family history positive, we do the BRCA1 to young age, less than 40 years of age. Female develop this. Triple negative means there are three things I told you: ER, PR, and HER2. All together we call as a triple negative. So if these three things are negative, means they are high risk of developing the recurrence, and we check the BRCA. That's it. So this is how we treat clinically the patients. So this is all about the breast cancer. Very quickly, overview of complete breast cancer. Any question? Any question in house?
Hello.
Okay, no, sir.
Sir, the difference between chemo and radios, actually, the tumor size is more than in both the tumor size is more than 5 millimeter, and
Not
nodes.
millimeter, sir. Centimeter, sir.
Okay, sir. Centimeter, and nodes are present in both also, sir. Is the difference metastasis in chemo and radio?
Basically, when the tumor is large, node is positive, before any treatment, you must go for the neoadjuvant chemotherapy because it's an advanced disease. It's not limited to breast. Now it's breast to the axilla. Na? Lymph nodes are also positive. So it's a locally advanced disease. So you give 4 to 8 cycles of chemotherapy and then try to operate this patient and then give the radiotherapy. So sequence across the globe is surgery, chemotherapy, radiotherapy, and hormonal therapy. This is the pattern, right? Not from day one, all the treatment will be started at the same time. So today you start did surgery, breast conservative, tomorrow you start chemotherapy, day after tomorrow you give radiotherapy, and after that you start hormonal next day. It's not like that. You do the surgery. After 21 days, you start the chemotherapy. After 3-4 weeks, you start the radiotherapy. And once the radiotherapy finish, you start the hormonal. This is the pattern of treating the patient. You can't start all the 4-5 treatments on the same day. Is that clear?
Okay, sir.
Is that clear or not?
Okay, sir.
Yes.
Excellent.
Yes.
Excellent. So I'll switch on the next questions. Probably I discussed a lot on breast, but it's, I think, important, most important for especially for the female. 23-year-old. So write down your answer is right or wrong and check your score. 23-year-old obese female with known tuberculosis patient presents with ulcerating nodules on the back of her leg. Which one of the following is the most likely diagnosis? Erythema marginatum, erythema induratum, nodosum, vulgaris, or lupus pernio. This is the picture for you. This is a This is a spot diagnosis questions as well as this is a skin question. This is the picture questions. Yes, so this is the question. This is the picture. This is the question. And this is the picture. So out of 40, 50 people, we have just 3 answers. Now 4, 5 answers only. Dr. Hemsagar, any comments, sir, from your side? Anything you would like to tell? Dr. Hemsagar? Dr. Dilakshi, any comment? Dr. Dilakshi, any comment?
Sir,
Any comment?
erythema induratum specifically for the tuberculosis patients. So this
Oh,
patient is 23 years old, known
okay,
patient with tuberculosis. So I thought it's a C, erythema induratum.
excellent. So this is erythema induratum. You're absolutely right. So erythema induratum is paniculitis under calves. It occurs mainly in the woman, but it is rare now. Historically, when it has occurred, often been concomitant with cutaneous tuberculosis and was formerly thought to be always a reaction to the tuberculum bacillus. It is now considered is not associated with single blah blah. That's not much important. It's all literature. So this is a classical. Fix this picture in mind. What's the clue here is a tuberculosis patient. So tuberculosis patient, number 1, associated. Number 2, back of the leg or calf is the commonest site for induratum, and this is classical for induratum. Classical. So you just keep the picture in mind. So if your answer is wrong, make it wrong or right. Check your score end of the day. Third question. 57-year-old woman. So don't expect easy questions in exam. I'm not trying and here to scare you. I'm trying to open your eyes. This is a wake up call for you, especially exam going, right? If you think that I'm absolutely well prepared, then this mock will open up your eyes. 57-year-old woman who underwent emergent cholecystectomy for a perforated gallbladder 3 days prior. Now he has a fever of 103 and is complaining of chills. The patient has not been ambulating and says she is a great deal of pain at her incision. What is the most likely cause of her fever? Is it atelectasis? Is it UTI? Is it wound infection? Is it deep vein thrombosis? Is it abscess? That's it. Your time starts now.
UTI.
Yeah, let's answer the other. We'll discuss. Thanks for your prompt reply. Probably you are very well prepared today. So put your own answer rather than someone else answer. Put your own answer. If the same questions comes in exam. So wound infection, who is wound infection? Anyone wound infection? Dr. Jomoli Joy.
Yes, sir.
Yes,
Any
sir.
comment, Dr. Jomoli?
Uh, so the patient had surgery 3 days back,
Okay,
and the fever is high grade with chills,
okay.
uh, and there is pain at the site of the incision.
That could be there, no? Operated cholecystectomy done. So pain could be there even after 5 days, 6 days, 7 days. So what makes you to think of wound infection? And do you think the wound gets infected in just 3 days? Do you know the protocol of post-op fever and time frame? Do you know post-op fever and time frame? Yes or no?
No, sir.
So today you will enjoy this class. Wonderful.
Yes.
No problem. I will be happy. At least you are interacting means I'm very happy. 0 to 1 day.
Yes, sir.
I mean 0 to 1 up to 3 days. Then 3 to 5 days. 5 to 7 days, and more than 7 days. In general, this is how. So first of all, what is the most important thing is the duration. After how many days they develop fever? If somebody says, oh, operation done, just three hours before operation done and patient have fever. Just 3 hours. Now is post-op, shift to the ward, patient is stable but 103 fever, same. Within 6 hours, the diagnosis may change. After 3 days, diagnosis change. 5 days after diagnosis. So I want you to not mug up the things. I will make you very, 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 very important. So first of all, see the cartoons, this cartoon. So first part is lung. And what is in the lung is a wind. Lung. Below the lung, there is a urinary bladder, water. Below urinary bladder, people are walking with legs. So wind, water, walk. Fourth thing is a wound. Fourth thing is a wound. And fifth is a weird. So this is 5W given in the books. 5W. Wind, water, walk, wound, and weird cause. So go up to down. So if something goes wrong, it goes to the wind. Wind means airway, air things. So atelectasis. So atelectasis usually develop in 1 to 3 days. 1 to 3 days if somebody comes to you. Why? Because patient is intubated, patient has anesthesia, patient has a lot of secretion in the chest, right? So atelectasis is the first things. Post-operative, immediately if somebody says that, oh, fever on the day 1, atelectasis. How you prevent? Pre and post-operative chest physiotherapy and antibiotic. So prophylactic antibiotic is given to the patient for this reason only, right? No need to mug up. Clarify your concept. Why we are giving antibiotic prophylactic to some patients who is going for appendectomy, going for oophorectomy, going for this gallbladder surgery, going for some hysterectomy, blah, blah, right? So this is prophylactic antibiotic can be given to prevent the infection. So this is how you learn. 3 days or beyond the 3 days, but less than 5 days. Lots of patients, water means something related with the genitourinary tract, so there is a catheter. So most of the patient have a Foley's catheter post-operatively. So this catheter is a culprit. It's a foreign body and that caused the infection. Here the answer is UTI. Why? Because it's a 3 days before 3 days. So now it must be 3 days, 4 days, 5 days. So here the answer is 3 days, but they may change the answer. That is why I'm giving you all story, right? So atelectasis is up to 3 days. So wind is done, water is done, walking. If you don't walk, you develop DVT post-operatively, deep vein thrombosis, right? So deep vein thrombosis usually developed beyond 5 days or so, right? So walking, if you are not walking, do DVT, and DVT is a cause of fever. So look at what they develop fever more than 5 days to 7 days in between. It's a DVT. DVT can cause fever, right? And then wound. So wound usually comes in the picture after 7 days, 7 days to 2 weeks or 15 days, 7 to 15 days, because it takes some time. Na? Today you operated and tomorrow not all the bacteria will grow at the wound site and oh, fever. Doesn't works in that way. There must be some colonization, there must be some inflammation local. So it takes usually 5, 6, 7 days beyond and up to 15 days. And if patient has a like fever, right, more than 15 days, it should be a deep-seated abscess that is called a weird. So in weird, one is abscess. In weird, what comes? Abscess. In weird, what comes? Drug. Some drug like cytarabine drug can cause fever. So weird. So wind, water, walking, wound, and weird. So this is exactly from the book, nothing from my own story, right? But you need to know. I had given you the nice cartoon, so you want to mug up to down. This is how I remember. So I'm trying to give you the easier technique over a period of years. What I learned, I try to give you just to make it easy. Otherwise, you will again forget tomorrow. So this is the chart. 0 to 1 days wind, as I told you, right? It is very clear cut, right? So this is a wind. Wind is a lung. Lung means atelectasis, right? 3 to 5 days wind, then water. So water is UTI, is water. Then walking. Walking is deep vein thrombosis, pulmonary embolism, right? Then wind, water, walking, wound. Another wound operation. 7 days, and 7 to 15 days is this weird deep-seated pain, drug, fever, blah, blah. That's it. This is from my side. Any question? Any question? Yes, doctor, you told the wound infection. So you got Jomoli, you got cleared.
Yes, sir. It's very clear now, sir.
Wonderful. So keep in
Yes,
mind,
sir.
we just mug up while we are going into the round. We just give, give antibiotic, give gentamicin, give monosep, give ceftriaxone, give this cephalin, give cefoperazone, give sulbactam, give meropenem. We don't think. I want you to think what happens, why fever happens, what is the day. This is how I treat patients clinically. So if some patient in tomorrow OPD or ICU tells, sir, fever, post-operative fever, then I will not apply my brain. I'll look one by one. What is the day? Is it atelectasis? It is a wound. It is a water. It is a walking. It is this. I can easily make up the diagnosis. It's not rocket science. Now I had given you the algorithm, how to approach. This is algorithm. Got it? So don't think
Yes, sir.
just
Yes, sir.
monotonously. Think little out of box. Next questions. 26 years old lady. Make your right or wrong. I want each and everyone score end of the class. Right? Don't shy to send me. We'll improve it together. 26 years old lady present with a high fever, lower abdominal pain, purulent vaginal discharge. She looks very unwell. What is the most appropriate management of this patient? Tetracycline 250 milligram 6 hourly, doxy 100 12 hourly, and metronidazole 400 12 hourly, ceftriaxone 2 gram, IV with doxycycline, ceftriaxone 2 gram, IV with doxycycline 500 milligram, ofloxacin 12 hourly with metronidazole. So before you think over it, 15 second, 30 second, I would be happy. I'm unstoppable man. I can speak 6 hours. But you think over it, right? So if you don't know the diagnosis, 99% your answer is wrong. So I want you to understand diagnosis. Those interacting with me, just give me 3 answer again. Our triad, I make on my name Munjal triad. Diagnosis, investigation, treatment. You must do, you must know of every MCQ. So here no diagnosis is given. So first you need to make diagnosis. First you make the diagnosis, what this patient is suffering from. Then jump on the treatment. How do you know without diagnosis what the treatment? Just clue for you. Post your answer. Yes, Dr. Rahima, any comment?
Is it pelvic inflammatory disease?
Pelvic inflammatory disease. It's a very broad term, pelvic inflammatory disease. So which pelvic inflammatory disease? Can you tell me 5 names of pelvic inflammatory disease? Dr. Rahima? Am I audible to you? Dr. Rahima, are you there? Yes or no?
Yes, sir.
Can you tell me 3 names of pelvic inflammatory disease? Which
Yes,
disease
sir.
comes under?
Endometritis, salpingitis, then
Endometritis, salpingitis, then
tubo-ovarian abscess.
tubo-ovarian abscess. More common, I mean, this is your very
In this,
famous.
it is salpingitis, sir.
You told salpingitis, you told. Anyone else? Anyone else? Pelvic inflammatory disease, what comes under the label of pelvic inflammatory disease? Anyone? Simple question. It's not. Sorry?
Trichomoniasis.
Trichomoniasis. Okay.
Bacterial vaginitis.
Bacterial vaginitis.
Herpes.
Herpes.
Chlamydia,
Chlamydia. Chlamydia.
Gonorrhea.
Gonorrhea. So this all are, you are giving me the list of sexually transmitted disease or PID or both? So go and read.
sometimes PID can be caused by STD.
Fair enough. So go and read. Absolutely high yield question. What is pelvic inflammatory disease? Exactly, read from book. Read from book. One of the biggest commonest problem across the globe in every female is pelvic inflammatory disease. Got it? So read it. And second thing, you go and read it, sexually transmitted disease. So you need to have clear-cut mindset. These are the pelvic inflammatory disease. This is sexually transmitted disease. So what is this? Or it's a combination of both. What's the diagnosis here? Anyone open? What's the diagnosis?
Salpingitis, sir.
Salpingitis. So salpingitis, let's go back and check. Is it the salpingitis? Let's go back and check. Is it the salpingitis? So what happens in salpingitis? Anyone? Those who answered me salpingitis, tell me what happens. Forget about this scenario. What happens exactly when patient comes to you in your OPD or in gynec OPD, blah blah. When you think, oh, this patient has a salpingitis. Oh, this patient has ectopic pregnancy. Oh, this patient has a some sexually transmitted disease. So what makes you to think of salpingitis? Tell me.
Lower abdominal pain with purulent,
Okay, lower abdominal pain. What else?
purulent vaginal.
Sorry, I muted because I want to mute background people. They don't understand. So you unmute now. I muted all. You unmute now and talk.
Vaginal discharge purulent, sir.
Vaginal discharge purulent. Vaginal discharge purulent. Okay, so this looks like a salpingitis to you. What's the treatment of salpingitis?
Doxy 100 mg BD, sir.
Okay, so only doxy? Fine. So no problem. Don't waste the time. You go and read the PID and tell me the treatment personally. Your homework is to read complete PID, organism commonest, and its treatment. Right? So that's the homework. This is chlamydia, common STI, sexually transmitted infections caused by specific strains called as a chlamydia trachomatis. It is transmitted through the vaginal discharge or semen and can be transmitted through the vaginal contact or oral or vaginal or anal sex without a barrier method like a condom. Chlamydia is more common in women than in male, and this is a severe case. So ceftriaxone, or another brand name in India is a monosef, that is ceftriaxone. Anyone tell me which is a ceftriaxone or an antibiotic? Somebody asked me in morning antibiotic. Which generation antibiotic it is? There are 5 generations of cephalosporin. 1, 2, 3, 4, 5. So this is which generation? Ceftriaxone.
Third generation IV antibiotic.
Third generation cephalosporin.
Third generation cephalosporin. Excellent. So this is again a question in exam. So you must keep in mind. So this is what the thing is. So you need to understand what is the diagnosis. Without diagnosis, it's very difficult to answer treatment part. So everyone, very common questions. Go and read the sexually transmitted infections. The same thing I explained. Next question.
So should the partner be treated, sir, in such cases?
Yes, partner should be also treated, because once you only treat the patient, again he will have the infection. So both partners should be treated.
Okay, sir. Thank you.
68-year-old woman, write down right or wrong assessment at the end of the class. 68-year-old woman is found on routine CBC to have hematocrit of 32%, MCV 70, stool is Heme negative. What is the next step? Colonoscopy, sigmoidoscopy, barium, enema, upper endoscopy, 2 more stool tests now, repeat stool test in a year, and capsule endoscopy. Only 3-4 answers. Easy questions. Easy questions. Yes, Dr. Asmat Danish. Any comments, sir? Dr. Asmat Danish. Any comments, sir? No comment. Dr. Farah, any comment? Dr. Farah.
Sir, A, colonoscopy.
Okay, so let's you and me only discuss now these questions. Okay, are you okay?
Yes, sir.
Wonderful. What's the diagnosis or possible diagnosis? Or what could be the diagnosis? Not confirmed diagnosis, tentative. What do you think this 60 years of old gentleman who has a reduced hematocrit, means some kind of anemia, right, which is marked as a low MCV, right? So likely some 68 years of male with iron deficiency, right? What do you think that where is the problem? Problem is in the bone marrow, problem is in the intestine, problem is in the what? Why hematocrit low? Why MCV low?
Sir, age criteria?
No. So what's your likely diagnosis now, or what we called in a broader way the differential diagnosis of this patient? What it could be? If I evaluate this
GI,
patient, what it can be happen, or what direction I will investigate this patient?
colon cancer.
Colon cancer. Okay, fine. Fair enough. This is the most appropriate answer. Na? 68 years with anemia. What you don't want to miss is a colon cancer or colon CA. That is a possible. That's a possible. Why possible? Because we did not did the endoscopy, right? Once we did the endoscopy, confirm the diagnosis, then it's so. This is the first thing, right? Now, what do you think? What is the best when you're thinking colon cancer? What is the most sensitive and specific test across the globe? Yes, Farah.
Sir, biopsy.
A biopsy, but how you do the biopsy? Means colonoscopy, na, basically. You do the colonoscopy and biopsy, na? Colonoscopic biopsy. Isn't it? Yes or no? So you enter the colon, you see the growth. If it has a growth or ulcer or mass, you take a biopsy. So colonoscopic biopsy. So basically do colonoscopy apply means colonoscopy biopsy. Every time it don't need to write specifically colonoscopic biopsy. Colonoscopy implies it's a colonoscopic biopsy, right? So colon CA you are suspecting. So here the answer is a colonoscopy. Why not sigmoidoscopy? 40% of the cancer you can miss. Example, this is colon in general. Ascending, transverse, descending, sigmoid colon, rectum, anal canal. This is the general picture. This is a cecum, right? So if you do the sigmoid, it will reach up to this only. Sigmoidoscopy means it won't go beyond sigmoidoscope. And beyond sigmoidoscope, there is a descending colon, there is a transverse colon, and there is the ascending colon. So 40% of the cancers are situated in this part. Means 40% of the cancers are missed if you are not doing complete full strength of colonoscopy. That is why colonoscopy is a better answer than sigmoidoscopy, because we don't want to miss the 40% cancer. Barium enema, you get the idea about the growth or ulcer or mass, but you cannot do the biopsy. Barium enema is an investigation, not the diagnostic team. Upper endoscopy is not required, right? If the colonoscopy is normal, then you go for the upper, right? Just to rule out the upper things like CA esophagus, CO stomach, G junction, blah blah, right? Two more stool test is not required. Two more stool test. Just write down, fix in your head. I fix in my head, being oncologist, any male or female. Important word is male or female. Any male or female, not just female, not just male or female, more than 50 years plus anemia or low hematocrit. Anemia means low hematocrit. Rule out GI malignancy, either upper or lower. That's it. One line. This is written in many Davidson, Harrison, Oxford. Lots of one line is written. 50 years male, female, anemia, never ever miss underlying malignancy. This is what the written in a different way in the books. I am trying to make it the simpler version, right? So two stool more test, whether it is positive or negative, you need to do colonoscopy, because why the anemia develop? Stool test may be negative. That does not mean, right? Initially, when patient has chest pain and you do trop T, trop I and CKMB, if it is not negative, then you can say, oh doctor, oh patient, you don't have any acute MI, you go home, enjoy. And after 6 hours, he will come with the cardiac arrest, right? Because initially it could be normal. Got it? Repeat stool test in a year is not required, and capsule endoscopy is also not required before colonoscopy. So this is the appropriate answer. This is how we have to rule out as well, not just the answer, but why this is not the answer. That is also art. And if you cultivate that, then you are a champion.
Sir, given this question, what is it that could be a factor for us to lean more towards a colonoscopy as opposed to an upper endoscopy?
Because usually the lower GI, right, they usually present with a melena, number one. History is like that. Lower, little more going 1 more minute in detail. Upper GI usually presented with melena, lower GI bleeding usually present with the fresh blood, right? Easiest things, number one to do is a colonoscopy. Number 3 is more common in terms of incidence and prevalence. Is a colon cancer is more common than stomach and esophagus cancer, right? So it is a protocol, I mean, international. So first you need to rule out the lower GI malignancy, but the answer is yes. If the lower GI is completely normal, you have to go the upper GI endoscopy, right, from the oral cavity to up to the this duodenum, where up to your upper GI endoscope reach. Third question: if the upper and lower both normal, then what to do with this patient? Then the answer is capsule endoscopy.
Okay, sir. Thank you very much.
You got it? So
Yes, sir.
capsule endoscopy has a role when you have anemia, but upper and lower GI endoscopy normal, because there is a one blind loop where the upper GI will not reach, lower GI endoscope will not reach. Somewhere below the ileum, terminal ileum, there is a loop, right? There is a limitation, na? That upper GI endoscopy reach and lower GI endoscopy. So there is a one space. I called it as a blind space where upper GI, lower GI will not reach. And if the bleeding is from that place, only the way to find out the bleeding or having a low hematocrit or some occult bleeding is the capsule endoscopy. So you make capsule, there is a radio camera in the capsule, it go from the mouth to anus and completely take up the picture, and wherever the bleeding is there, you go and fix up it. That's it. By the laser treatment. I have one patient in my OPD in last 20 years where we have a same thing. Some patient, just very quickly, 1 minute history, 70 years male, presented with recurrent anemia, transfused more than 10 units of blood out of the town. Unfortunately, somebody did bone marrow biopsy. Everything has been done, but still occult blood is positive. Upper GI endoscopy done, lower GI endoscopy done. We did a capsule endoscopy for this patient, my patient, and found to have there is a AV malformation, AV, atriovenous malformation, and he is leaking the blood from there. And we did a laser treatment. We tried to seal that AV malformation. And after the follow-up of 1 month, 2 month, 3 month, that patient has from like 6, 7 HB to around 12, 13. He was very happy. It's little interesting case for me as well in my practice. But this is how we treated that patient with the laser ablation of AV malformation. So there is a leak from at arteries and venous when they are joining. There was a malformation, either congenital, acquired, I don't know, but that was the final diagnosis, and we sent the patient to a gastroenterologist and he, I mean, offered the laser, and with the laser that leak was stopped and anemia was stopped, and then gradually hemoglobin going up without blood transfusion. So colonoscopy was done, endoscopy upper was done, eventually capsule. Is that clear?
Yes, sir. Thank you very much.
No problem. Next question: a patient brought to the ED, that is emergency department, after a seizure. There are a lot of chat with me, but I explain the same thing, so I'm not going much in detail. I'll share this PowerPoint with you, don't worry. Patient brought to the emergency department after a seizure leading to a prolonged immobility on sidewalk. He has a dark urine, myalgia. What is the most urgent step in this management of this patient? You are going to go for urinalysis, urine myoglobin, EKG, that is electrocardiogram, or ECG, CPK, creatinine phosphokinase level, phosphatase level, and creatinine. Quick. It's easy questions, I guess. Yes. Yes, quick. So I think almost everyone had given. Dr. Monica, any idea, Dr. Monica?
It may be a case of myoglobinuria.
This is case of
Maybe a case of
myoglobinuria, right? By how do you know that this is myoglobinuria?
Yes.
How do we know?
Also because the question says he has dark urine and myalgias.
Myalgia and what?
Myalgias.
So dark urine and myalgia is a indication of myoglobinuria, right?
Yes, sir.
Okay, so why don't you do the urine myoglobulin level, confirm the things, and then you go for further treatment? You don't want to do myoglobulin, it is their option. Urine myoglobulin level.
Sir, the question is saying after seizure, he led to prolonged immobility. That means ECG, some cardiac arrest might have occurred. So ECG is the most urgent step next.
Okay, so how the cardiac arrest happen in this patient? Because of what pathology the cardiac arrest will happen? Because he has a complaint of dark urine and myalgia. So in myalgia he will not die. Dark urine he will not die. Then why you want to do the EKG?
Acute kidney injury leading to hyperkalemia.
Great, wonderful. So that's a little clue. So this myoglobulin, right, will cause a renal failure. And another thing beyond that is like when there is a muscle injury or crush injury, lots of potassium released from the muscle. It's an intracellular component, right? So lots of when muscle crush, what happens? All the intracellular or inside the muscle, lots of potassium released in the blood. There is a sudden surge of potassium in the blood. Hyperkalemia, and hyperkalemia will kill the patient by doing the ventricular tachycardia or ventricular arrhythmia. So hyperkalemia is a medical emergency. Medical emergency. So if you ignore high potassium, right, in your OPD or in ICU or NICU or in intensive unit or high definition HDU, then you are losing the patient. Believe me. Never ever, even with asymptomatic patient hyperkalemia, don't take it lightly. Try to investigate, evaluate, he will die. Not because of hyperkalemia leading to, this is potassium 6.5. See, those who have background noise, please make your mic mute if possible. Right, so this is what the thing is. So normal potassium, first before abnormal, they are not given, but I'll give you the idea about normal things. So potassium here normal is 3.5 to 5.5. This is normal range. Less than 3.5 hypokalemia, more than 5.5 is hyperkalemia. Don't get confused between kalemia and calcemia. Kalemia means potassium. Calcemia means calcium. So there are a lot of people confusing kalemia and calcemia. So we are talking about kalemia, not calcemia. Kalemia. So this is hyperkalemia. Hyper means high, kalemia means potassium. So when there is a hyperkalemia 6.5, first and foremost thing is to do the ECG. You can't do anything before EKG, right? EKG, ECG is the same thing. Yes, if it is changes, yes. If you see some changes in ECG, what changes? Yes means what? Tall T wave. This is exam question. Tall T wave. Have you heard of tall T wave? P, Q, R, S, and T. This is tall T wave. P, Q, R, S, T. Tall T wave. Normally it's like P, Q, R, S. This is T wave. But this is tall T wave, right? Spiked T wave. And that is a signs of hyperkalemia. So if you have a hyperkalemia in the serum, so if you get a call from ICU that I got a one patient whose potassium is 7, what to do? First and foremost is to do ECG. If there is a tall T wave, give without calling anyone. Don't call your intensivist. Don't call your cardiologist. It will waste the time and patient will die. So give simply calcium gluconate. Giving is not a rocket science. It's a simple calcium. You are giving calcium. That's it. So other two things, calcium gluconate, another is calcium chloride. Sometimes they ask you calcium chloride. So don't get confused. Either calcium gluconate or calcium chloride, you infuse patient intravenously, give. What it will do? It will work on the heart. It cardiac cell membrane. It stabilizes the cardiac cell membrane. So patient will not die because of arrhythmia. Why? Because you relax the heart. Cardiac cell membrane is stabilized by blocking the giving calcium gluconate. You block the cardiac channel, cardiac membrane. So excess potassium will not kill the patient by doing the ventricular arrhythmia, flutter fibrillation. Right? And another way you check out the pseudothrombocytopenia. Pseudothrombocytopenia is more common. Why? Because the patient KCL, say patient is admitted for hypokalemia. On admission, is potassium is 2.3. You started IV KCL, 2 ampule, 4 ampule in pint. And from the same vein, somebody is collecting the blood. On the same where the KCL is going, same just above the KCL drip, somebody is collecting phlebotomist drip and say, oh, 7, it's pseudothrombocytopenia, hypokalemia. Right? Another problem is one is a improper collection, and another common in our practice is a hemolysis. So blood is collected at 10 o'clock by some phlebotomist, and by the time it reached to the lab by 11 o'clock, especially in corporate hospital, there are lots of patients. First floor, 7th floor, 10th floor, 9th floor, 11th floor, ICU, emergency, and then he give the sample to the lab. Meanwhile, what happens? He collected blood at 9 o'clock and is giving the sample 10 o'clock to the things. So meanwhile, what happens? There is a hemolysis in the blood, in the test tube, EDTA. We collect usually CBC in EDTA. So what happens? There lots of potassium is liberated from the hemolyzed RBC. So potassium is elevated and it is called pseudothrombocytopenia, sorry, hyperkalemia, sorry, pseudohyperkalemia. So these are the two main common. Either sample collection is improper, or there is a prolonged waiting of EDTA, or it is not sampled or not processed on time. So more time it remains in the room temperature or not processed, then there is a gradual hemolysis of the collected RBC in the test tube, and that causes the hyperkalemia. So what I'll do, being a hematologist, if I get a call of hyperkalemia, what I'll do? I'll check, okay, KCL is going or not going. Chalo, one problem is solved. Second, right? When I call the lab directly, what time the sample collected? When you process, oh, after 2 hours, don't worry, forget about it. Collect the sample immediately in front of me and run it. Now it is 3.9, normal. Problem is solved. So this is biggest problem, right? So you are try to rule out this. If it is genuine, you do it. Again, it is high, give calcium gluconate. After giving calcium gluconate, try to reduce the potassium, and you can reduce by 2-3 ways potassium. One is glucose insulin drip. Some people are saying GI drip, glucose and insulin drip. And if acidosis, you give soda bicarbonate, because acidosis can cause hyperkalemia. So if you reduce the acidosis, hyperkalemia will reduce. And if your measure is failed, calcium gluconate given, this potassium reducing things done, still it is high, last but not the least, go for hemodialysis. So this is absolutely complete algorithm how you treat clinically the hyperkalemia. Hypokalemia is not medical emergency. Hyperkalemia kills the patient immediately. I have seen few patients, right, who came into the emergency, check the potassium, it's very high, cardiac arrest, die. So don't take it hyperkalemia lightly. Take home message. Any question? Any question? Yes or no? No answer. No problem.
Sir, sorry, sir. What is the rate of calcium gluconate in for such patients, sir?
Usually they don't ask the dose, but for your knowledge, we give 2 ampoules of calcium gluconate, right? In 100 ml of NS, normal saline, over 30 minutes.
Okay, sir.
Right? Intravenously we give, right? First we give calcium gluconate, and then immediately we'll start the GI drip or glucose insulin drip. And then we check every, say, for 30 minutes the potassium level. Once it is normal, we reduce the GI drip because now it's normal, right? And even if after this measure it won't going down in next 6 hours, then probably we may take patient for dialysis, right? Because until and unless you treat the problem primary, this hyperkalemia will not go. No? You have to reduce the potassium, right? Because calcium gluconate effect is also lasts for, say, for example, 6 hours or 8 hours. So you need to continue 8 hours until and unless these things, right? Because after 8 hours, again, high potassium, again, risk of this arrhythmia. You understand? But this is the initial step. When somebody comes in the emergency, give calcium gluconate, reduce the potassium. Most important is GI drip, right? And glucose and insulin. Some people are saying, why you want to give, sir, insulin and glucose, both the things at the same time? So primary thing is the insulin. What insulin does, insulin shift the potassium from plasma to the cell. Plasma to the cell. So in plasma, the potassium is high. Now it goes inside from plasma to cell. It reduces in the plasma, so potassium will get normal. But what the another problem is that along with the potassium, glucose also falls, because glucose also go with the potassium. Got it? So when you give the insulin, potassium go inside the cell, sugar will or carbohydrate will go inside the cell, and that is why the potassium level in plasma reduce and glucose level is also reduced in plasma. That is why you have to give the glucose. That is why you have to give the glucose insulin drip. So glucose is otherwise not needed, right? But because of insulin you are administering, there must be hypoglycemia. So you have to take care of hypoglycemia as well. Otherwise, patient has 40 sugar, you will be hypoglycemic coma. I will go. So you have to tackle the both the things at the same time. Is that clear?
We have to give the dextrose insulin drip, right, sir?
Yes. So there are various names: dextrose insulin drip, glucose insulin drip. All are the same thing. Dextrose is basically glucose.
Yes, sir.
Next questions. Elderly, last 2-3 questions, just bear with me, very interesting. Elderly man brought to emergency department by his grandson is not responding, but he does have a faint carotid pulse. His heart rate is estimated to be 150, blood pressure is 50/24. His skin is cool, pale, damp. Your request ECG, which shows the following rhythm. Where is the rhythm? This is the rhythm. Now, what's the things? Is it second degree AV block? Is it AV nodal reentral tachycardia? Is it sinus bradycardia, or it is ventricular tachycardia monomorphic? This is the rhythm. This is the rhythm. This is the question.
Monomorphic tachycardia, ventricular tachycardia.
Let's see. You are brilliant. Everybody is brilliant. Probably you attended my earlier lecture. Or you mug up this easily. Good, I am happy. Very happy. So why this is monomorphic? Monomorphic. Mono and morphic. So if you see the morphology is the same. If you see the morphology is same. If you see the morphology is same. So this is why I called it. No need to mug up. I am extremely against mug up, rectify. Every word has its meaning. Only just thing is we need to apply our brain. Mono means monotonous or same. Monotonous, same. Morphic means morphology. So same morphology. So this is same, this is same, this is same, this is. What is polymorphic then? This is polymorphic. Nothing is same. Every bit is a different bit. Polymorphic BT. That's it. So this is VT. This is VT, right? Monomorphic VT. And what's the treatment? Who has given the answer? What's the treatment, doctor? So we need to do three things. One is the diagnosis, another is investigation, third is the treatment. So we did a diagnosis. This is VT, basically monomorphic. Investigation is done by ECG. Now what is the treatment? If they ask you the same question, now what is the treatment of this patient?
Since the patient is unstable, we have to cardioversion, synchronized.
DC cardioversion.
Synchronized?
Sorry, sir.
How? What are the indication of unsynchronized? Forget about synchronized. What is the indication of unsynchronized cardioversion? Only two indications. Mug up. Ventricular tachycardia, pulseless VT. We called as a shortly pulseless VT and pulseless VF. These are the only two indication in ACLS, BLS where you need to give unsynchronized cardioversion. That's it. I have given the last time the homework, but I am thinking that I am the only one who is doing the homework of whole the week, trying to prepare the slide slow, PowerPoint, investing my lots of time, energy, efforts at no cost. But nobody is doing the homework, so not a good part. Go and do it. Homework. How you differentiate synchronized versus unsynchronized. What is basically synchronized and what is basically unsynchronized. When you give synchronized, when you give unsynchronized. Go and read it. We'll discuss.
So what are those two conditions? One is ventricular fibrillation and the other one is pulseless VT.
Pulseless VT or unstable. Yeah, so this is all VT.
Okay, sir. Thank you.
Patient came to you and you found this, his BP is 160/100. is not on any medication yet. Lab investigation show creatinine 1.1, that is normal. Sodium 145, upper normal. Potassium 3.2, little lower. Bicar 30, normal. What is the diagnosis? Essential hypertension, pheochromocytoma, Addison's disease, primary hyperaldosteronism. I need the explanation, not just ABCD. What's the diagnosis? 40-50 people, answer is 3 or 4. Dr. Dilaksi, any idea, Dr. Dilaksi? I want to discuss with you, Dr. Dilaksi.
So I think this is a case of essential hypertension.
Okay, so we'll discuss.
because-
One minute, doctor, 1 minute. Sorry to bother you. So you think this is case of essential hypertension?
Yes, sir.
Okay. So why the potassium is low in essential hypertension?
Sorry, sir, I didn't get you.
I'm saying why the potassium K 3.2. This potassium is why low in essential. What is the definition of essential hypertension? You see a hypokalemia in essential hypertension?
No.
Why the potassium is low in essential hypertension? What I understood the definition of essential hypertension is the hypertension or primary hypertension or secondary hypertension. Primary is also called as the essential hypertension, where you get the hypertension with no obvious identifiable cause. You do liver function, renal function, cardiac function, hormone, electrolyte, pregnancy, everything is ruled out. You don't get any reason. Now this is essential hypertension. 90% of the patient has essential hypertension. Isn't it? This is what I understood. Am I right, everyone? Or any mistake in my understanding?
Yes, sir.
Right. So this is not essential for your knowledge because potassium is low. So there must be some reason for low potassium, isn't it? Yes. Anyone? Why additions? Why additions?
Primary hyperaldosteronism.
Yeah, that's the answer. But Varun told addition. So I want to understand why. What happens in additions, Varun?
No, sir, because of the hypokalemia point, I chose the answer, sir.
So, but in addition, hypokalemia or hyperkalemia?
Hyperkalemia, sir, sorry.
So this is hypokalemia. So how come it is addition? You got it?
Okay.
Yeah, I will tell you very important thing. So this is basically hyperaldosteronism is a disease in which adrenal gland makes too much of aldosterone, and aldosterone cause vasoconstriction and high blood pressure. So high blood pressure is because of aldosterone, high blood pressure, and also a low blood potassium. Many doctors are confused. I've seen for many years and years they are confused between Addison's and Cushing's. So let me go very quickly before ending up the session in next 10 minutes. Right? Increase cortisol, reduce cortisol. Right? This is the primary thing. Cortisol in plasma increase, cortisol in plasma is reduce. It's like increase sugar, decrease sugar. Right? Hyperglycemia, hypoglycemia, hypercortisolism, hypocortisolism. What's the name of hypercortisolism? Is a Cushing syndrome, where you get lots of cortisol, and when you have less, it is called Addison's disease. Simple. Basic. If you understand basic, you can answer any questions. This is how I remember. Everything gets elevated in hypercortisolism. Means cortisol is increased, blood pressure is increased, blood sugar is increased, sodium is increased. Only one thing which reduced is potassium. Reverse. Cortisol reduced, blood pressure reduced, patient present with hypoglycemia, patient present with the hyponatremia. Only thing will increase is the potassium. That's it. This is the what basic mechanism. If you don't understand any Cushing, Addison, blah, 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 if you understand this chart, you can answer hundreds of questions. Cushing, this is how I remember. So Addison's potassium is increased. Varun, are you getting me? Varun.
Yes,
So
sir.
potassium is increased, here the reduced. So Addison is gone. Is that clear?
Yes,
Is that clear?
Yes, sir.
Right? So simple chart. I took it from picture, but I memorize myself. Right? So I can able to produce immediately. So Addison's, everything is reduced. Addison's means lack of cortisol, all reduced, blood pressure reduced, glucose reduced, sodium reduced, this reduced, that reduced, everything reduced. What increased? Potassium. That's it. What is the result in urine analysis indicate the diabetic nephropathy? What is the result in urine analysis when you are suspecting or you are thinking that it's a diabetic nephropathy? Hyaline cast, RBC cast, proteinuria, hematuria. It's a easier question, I know, but many a times exam has easier questions as well. And let me tell you, most of the people do mistake in easier question. Fine, fair enough. Proteinuria, yes, that's it. Proteinuria is the answer. So proteinuria is the answer. So you have protein. So there are two type of protein, microscopic and macroscopic, right? Microscopic and macroscopic. So when you have a microscopic, every diabetic exam questions, when the diabetic supposed to check microglobulin, microalbuminuria, 1 month, 3 months, 6 months, 12 months, answer is 12 months. Once in a year, they must have to do the micro albuminuria, because sometimes, right, microalbuminuria cannot pick up on urine analysis. You cannot pick up microalbuminuria. Let me clarify you. You need to do one test that is called as a urine albumin creatinine ratio, or you need to do urine microalbumin specific test by which you detect the microalbuminuria. And microalbuminuria, if detected, then what to do? That means renal is going towards the failure. First, initially microalbuminuria, then macroalbuminuria. Micro cannot detect in urine routine analysis. Macro, like +1. Have you seen the urine report? Urine +1, urine +2 protein, urine +3 protein, urine +4 protein. What is 1 + 2 + 3? Amount of the protein. 1 plus means around 1 gram, 2 plus means around 2 grams, 3 plus means around 3 grams of urine. Protein, sorry, albumin is going in the urine. That is 1 + 2 + 3 plus. So higher the number, bad the kidney, bad the disease, right? So you want to stop at the level of microalbuminuria before it comes to the +1. You don't want your kidney to go +1 proteinuria, +2 proteinuria. So microalbumin, I can say 0 level. So you don't want to make it from 0 to 1, 2, 3, 4. So at the stage of 0, you give a drug. What is the name of the drug which prevents the diabetic nephropathy? Prevention. Or the drug which reduces the progression of renal failure in diabetes. Exam question. No options.
ACE inhibitor.
Excellent. Wonderful, 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 wonderful. ACE inhibitor. ACE inhibitor. Angiotensin converting enzyme inhibitor. Right? So if you give this drug, how it reduce, that probably you don't know. So what happens? This is a glomeruli. Right? You know glomeruli. So in glomeruli, right, where filtration occurs, what happens? The intraglomerular pressure increase, and that causes the proteinuria. Intraglomerular pressure increase in diabetes because of microangiopathy. It pressures inside the glomeruli is increased, and that causes the proteinuria. So by giving the ACE inhibitor, it reduces the intraglomerular pressure. So by reduce the pressure, flow is better, proteinuria is less, and that is how it acts. That is how it helps in a diabetic patient. So ACE inhibitor is a drug of choice. And what if the ACE inhibitor is contraindicated? Then what? What's the next drug of choice?
Low salt in potassium.
ARBs.
ARBs. The better name is ARBs. Angiotensin receptor blockade inhibitor. Right? So ARBs. ARBs. ACE inhibitor is the first line if contraindicated. What is the contraindication of ACE inhibitor? Exam question. Anyone?
So renal artery stenosis.
Bilateral renal artery stenosis.
Renal artery stenosis. Okay, fair enough.
Pregnancy.
There is a dry cough.
Pregnancy, excellent. Pregnancy is absolutely contraindication of ACE inhibitor, even ARBs as well. Excellent. Second, third.
Hyperkalemia.
Hyperkalemia, excellent, because it increases the potassium, so you cannot give the ACE inhibitor. Excellent. So these are the things. Few drug side effect you must know. Common, basic. They can ask anything. Believe me. And that's it. So last but not the least, same story I told you about the microalbuminuria and all blah blah. 26 years old G0 gravidas 0 woman is seen in the gynecologist office for a routine examination. She reports that she has been sexually active with the 4 partners and has been treated for a gonorrhea once in the past year. She has otherwise been healthy. Physical examination is unremarkable. The results of pap smear shows low grade squamous intraepithelial lesion. What is the most appropriate next step in the management? Instruct the patient to return immediately for a repeat pap smear. Reassure the patient of the results and instruct her to return to the office in next 6 months. Refer immediately for colposcopy. Test for the human papilloma virus type 6 and 11 and type 16 and 18. If you remember Dr. Munjal's triad, 99% you will not go wrong. Again, this triad: diagnosis, investigation, treatment. What's the diagnosis? Those who give the answer, think of diagnosis in your mind. What could be the diagnosis? Dr. Nishant, any comment? Any comment, Dr. Nishant, sir? Anyone? Last questions probably. Anyone? Open.
CA
Yes.
cervix.
CS,
cervix.
CS, who is the interacting with me? What's your name, doctor? Sorry.
This is myself, Dr. Monica, sir.
Monica.
Sir, I think colposcopy.
Colposcopy. Dr. Saher is saying colposcopy. Okay, so what could be the diagnosis? First, our simple step. Possible diagnosis, like that occult blood CA colon, like that. What's the little diagnosis? 26 years female came to the office. She is a sexually active with the multiple partners, other I can say. She also treated with sexual transmitted disease once last year. Otherwise, she is healthy. Physical examination is okay. Pap smear is showing low grade squamous intraepithelial lesion. For this lesion now, how you manage this? This is the question. That was the history. Young female, sexually active, past year gonorrhea, treated, now pap smear showing this. What to do?
HPV may be causing the CA cervix need to be suspected, and biopsy is the immediate thing. So colposcopy will be good.
So pap smear has been done, right?
Yes.
Pap smear is showing this. So what is the next? If pap smear is showing this, what advice you give to the patient? Report says with you now, low grade squamous intraepithelial lesion. What you are worried about this woman? What can be wrong, or what can happen down the line, or what you can be prevented? Sorry?
CA.
Okay, so we are worried about CA cervix. So what will you do now?
He can be HPV positive also.
Possible it can be,
Human
because
papilloma.
obviously because multiple sexual partners, so it must be until proved otherwise she is positive. Yeah. So what you want to do? You want to do colposcopy, you want to do HPV, or you want to do the biopsy, or what you want to do? First you want to what?
Go for testing.
I need one
HPV.
answer. You go for HPV or you go for colposcopy. So what you want to do? Because both
Go
are in
for
option. Na?
testing HPV. HPV, sir. First we go for testing that.
No need.
So say for example, HPV is negative, just for understanding, learning purpose. So you did a HPV for this patient. HPV comes negative. Then you leave this low grade squamous intraepithelial lesion as it is.
No, so better to do with the colposcopy.
Sorry?
Colposcopy.
we rare expectations. Women with low grade squamous intraepithelial lesion on cervical cytology screenings are referred for colposcopy because of the concern for cervical cancer. Recall that cytology pap smear is never diagnostic. Pathological examination of the biopsy specimen, colposcopic biopsy, is the only way to diagnose cervical cancer and precancerous lesion.
So if it came as ascus, then is it possible to do the HPV test and then go for colposcopy?
Yes. Yes. Whenever OSCUS has a three thing, what I think discussed in last lecture as well. So many people probably doesn't know the full form of OSCUS as well. Atypical squamous cell of uncertain significance. This is called OSCUS. So this is a cervix, right? So you got a this from cervix, you got a pap smear from the wall, and endocervix, you got a sample, you make it on the slide, you read the slide, and you found it is OSCUS. There are three possibilities in OSCUS. It could be a normal, it could be an infection, it could be a malignant. Three differential diagnoses of OSCUS, right? It could be something non-significant. That also sees atypical बरोबर squamous cell of uncertain significance. I don't know how much is the significance, but you should not miss. Why we are lots of discussion going on for Oscars, because what the thing is, what we don't want to miss is malignancy. If it is infection, we are happy. If it is normal, happy. But what you don't want to miss is malignancy. So once Oscars happens, what will we do? We will do the HPV. HPV is positive or negative. These are the two reasons, na? I mean two results, right? Once you do the Oscars from the pap smear, Oscars comes as a result. You do the HPV. If HPV is positive, you do directly go for biopsy. What happens if the HPV is negative in Oscars? Again, repeat after 6 months, not after 1 year or 2 years. Even after 6 months, sorry, again Oscars comes, then what will you do? You go for biopsy. And if again after 6 months HPV is negative, then you go for the routine screening test. So OSCUS is one of the differential diagnoses of malignancy. That is why you are chasing that patient. Just you don't want to miss the patient. So if some lump in the breast, very small, peanut or less than small peanut, right? You did everything, you did biopsy, right? But it's negative, but still the lump is there. You follow 6 monthly, 1 yearly, do mammo, sono, right? MRI breast, right? Because you want to pick up the breast cancer in early stage. That's it. So that is what you want to do it, and that's what you don't want to miss it. So that's it. So now check your score, check your score, check your score.
Sir, I have a doubt. I came across a question with the same history, sir, but the options included only, the option did not include colposcopy, but vaginal biopsy or endometrial biopsy. In that case, what should we go for, sir?
Vaginal biopsy is not a good idea, endometrial biopsy, because cervical cancer and endometrial carcinoma is more common than vaginal carcinoma, right?
Okay.
So if it is not fit to the, I mean, there is apparently no way to differentiate between CA cervix and CA endometrium, because they both present postmenopausal bleeding. There is this, blah, blah, because we are treating every day in and out. So even being after treating 20 years, how I differentiate it is endometrial carcinoma or it's a cervical carcinoma. So history looks like a same, but when we do the sonography, there is endometrial thickening, more favors of endometrial carcinoma. There is a lump in a cervix, or there is a cervical erosion, cervical mass, cervical ulceration. It goes in favor of this. Got it? So history, radiology, and biopsy will conclude the final diagnosis, right? But everything has its own role. So you can't judge on the one thing, right? Because I'm many times confused, and I'm thinking in my opinion, how do I differentiate between cervical carcinoma and vaginal carcinoma? Because both present with the vaginal bleeding, both present with sometimes postcoital bleeding, both present with lower abdominal pain, sometimes both present with the vaginal discharge. And how do I differentiate? So by examination local, by PAP, by doing sonogram or mammo or CT of lower abdomen pelvis, this is how we conclude, isn't it?
Okay, sir. Thank you, sir.
Excellent. So now check your score. Send me the score. And now that's all for today. I think I spoke 1 hour and 45 minutes. Hopefully you enjoy the lecture. So it's a very quick time for new user, especially the new user who attended my class first time. I want to have little quick feedback. What you exactly learned and how was the interesting, something new which you never heard in your life. There must be something, no? There must be something you are listening first time.
Sir, this is Dr. Lakshman, sir.
Yes, sir. Lakshman, sir. Yeah, I know. Yes, sir. Tell me. Mangaluru.
Mangalore, yes, sir. Yes, sir.
Yeah, because I just dropped you message. That is why I clicked.
Very simple explanation and practical, sir. So it is very straightforward. So nothing complicated and very simple. So excellent, sir. Excellent teaching.
Excellent. Thank you very much. You make my day Sunday. I will enjoy my Sunday after your words.
Yes.
Great. One more.
Great to get in contact with you, sir.
No, you are welcome, sir. My pleasure, sir. You are welcome. Yes, sir. Anyone else? Only one candidate in 40, 50, only one new? There must be many new.
Sir, this is Dr. Sarin from Kerala.
Yeah, sir.
So this is the first time I'm attending your lecture, and actually my friend who is currently practicing in Dubai, she only recommended me your lecture, sir. But I was not, even though she recommended, I was little, I was not at all convinced. But after today's lecture, I'm so happy, and I don't know how the way you teach, the way you explain. Hats off, sir. Thank you so much.
Great, wonderful. So give the feedback to your friends who recommended you.
Sure, sir. Sure.
Great, wonderful. Thank you very much. Anyone else? Sorry? Anyone from our old student? Something new learned? Then we'll pack up. Anyone? Something new you come across?
Difference between Cushing syndrome and
difference between
the table taught us the Addison's disease and Cushing syndrome.
Now it's easy for you, I guess. Simple.
Yes, sir. The paper was simple, wonderful. I'll remember it.
I also remembered it that way. So whatever the tips and tricks I have, I am absolutely happy to spread all my knowledge to our fraternity. Whatever. So I don't want to keep anything with me. All needs to be distributed. Excellent. Anyone else? Something new?
Thank you so much, sir.
Welcome, Dr. Monica. Anyone? Last.
Hello.
Yes, Inusha. I think you are from Sri Lanka.
Yeah, I'm Inusha from Sri Lanka,
Yeah,
and
I
this is
know
my
you.
first session, and I find it very useful. Thank you so much.
Excellent. Wonderful. Wonderful, Inusha, for your great feedback. Okay, fine. Thank you very much, all colleagues. We'll just keep in touch. I will probably come up with the 2 suggestions. Again, my homework. Varun given me homework of gynec. And also I got a homework for antibiotic this lecture. So we'll keep and catch up soon. Let me see my timings and all as soon as possible. I'll try to make it possible for you guys. I need to prepare well before presenting. So I'll start my homework from today only. I will not take break on Sunday. I'll start my lectures for this. Second thing is just again one humble request. I posted one Google review in the group of our this mock test. So it's a request. If you feel comfortable, you can give it. Thank you very much. Keep in touch and enjoy your Sunday. See you soon.
Sir, can I ask a quick question, please?
Yes, please, Sonali.
Sir, may I please know on the mock test, on an average of what percentage would be okay as an indicator to book the exam?
65 plus. Minimum 65 plus.
Okay, sir. Thank you very much.
Because I'm honestly speaking, I'm not discussing so complicated. I have a so bad MCQs with me, even getting 20% is difficult. But I don't want to scare you. I want to make you understand. And believe me, 100% paper is not toxic. Hardly 20-30%. So I'm trying to select the questions of little low level and middle level, not very toxic. You understand? If I have send you, then it's probably you scared, probably that come may not come. But these are the so frequently, routinely common day-to-day questions. What we discuss now, go and retrospectively, everything you see in practice, Hyperkalemia, you see ventricular tachycardia, you see you pap smear, every question, mammogram, every question, breast conservative surgery, every questions. You understand?
Yes,
So
sir.
colonoscopy, very hot favorite topic I'm selecting, right?
Okay.
And it's endless, na? I mean, even if I speak for whole days when I planning to start these things, right? So even we have 4 days, 5 days continuous crash course where we discuss like 9 to 5, 4 days we continue discuss these questions. Still, it is not sufficient. But what here I'm trying to explain to give you the basic concept and idea that how to interpret the questions, how to have a high yield points in the questions, what are the inclusion, what are the exclusion, how you make diagnosis, investigation, treatment. It looks simple tried, but if you practice in this way, na, believe me, you get lots of clarity. You understand?
Yes,
Because
sir.
now mind is little open. Oh, we are answering. We don't know what we are answering, right? We are just answering, but we don't retrospectively study the MCQ, what exactly it is trying to tell, right? So if you
Yes.
go by this way, okay, fine, this is the diagnosis, this is how it should be investigated, okay, this is the treatment. So in one question, say for example, you are solving 50 MCQ a day. By my sense, if you cultivate this practice, if you implement my practice, diagnosis investigation, means you are now practicing 150 questions, multiply by 3. 50 multiply by 3 is 150. You got it? And
Yes,
every
sir.
question will not come. What I discuss, it's not mandatory that whatever I am discussing, it will come in picture. But it is 100% sure if you understood my concept, you can answer any question
Okay,
related,
sir.
because I know for last many years what they ask, how they ask. That is why I'm just not monotonously, I mean, giving the reading the question, not interacting with anyone, and just
Thank you
oh,
so
this
much,
is
sir.
yeah, this is the answer. You go home. That's it. It is not like that. It doesn't work in that way. You understand, right?
Yes, sir.
So understanding the things will help. And you, if you have observed, in one question, breast cancer, I make 20 questions minimum, different. They can ask you in any way, right? So
Yes.
anyway, thank you very much all for joining and your for time,
Thank you,
right?
sir.
Also share your feedback in group as at least, right? So we'll keep in touch, and best of luck.
Thank you, sir.
You're welcome.